Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's program. In this week's program, we're in the second part of our analysis of motion segment integrity discussion related to the cervical spine. And in terms of this program in general, we're now in part 3. In our upcoming sessions, we're going to do the same thing with the lumbar spine. We're going to do a complete session where we review the procedure involved with taking the measurements and doing the analysis of motion segment integrity on the lumbar spine. And then I'm going to go through the permanent impairment and the apportionment discussion as relates to an actual lumbar spine case that did involve a loss of motion segment integrity. And backing up to today's session, that's exactly where we are in today's session. Today we're going to talk about the permanent impairment argument and the apportionment discussion in an actual cervical spine case that did involve a loss of motion segment and integrity. And in our last session, we did the measurements and we did the analysis of motion segment integrity in a 29-year-old female registered nurse who suffered a cumulative trauma injury while in the course of her normal work duties. And we found by reviewing the x-rays, and let's go to those now. Well, actually, we'll go to those in just a moment when we get to our causation and apportionment determination. But we found in those x-rays that the examinee did indeed suffer multi-level loss of motion segment integrity. And we found that there was decreased motion at the lower two segments of the cervical spine, that's C5, C6, and C6, C7, with compensatory increased motion at the two segments above. So that would be C4, C5, and C3, C4. And we found that the examinee had advanced pre-existing degenerative change and reversal of the normal cervical lordosis, which was advanced for a 29-year-old. Well, both of the areas of loss of motion segment integrity, meaning the areas that had increased compensatory motion and the areas below that had decreased intersegmental motion, both fit AMA Guide's definitions of loss of motion segment integrity, meaning one of those lower cervical segments that showed decreased motion showed only 0.7 degrees of motion from the extreme of flexion to the extreme of extension. And that was similar or analogous to AMA Guide's definitions of complete or near complete loss of motion. Complete or near complete loss of motion. And we said that 0.7 degrees qualifies as at least near complete loss of motion, if not complete loss of motion within the range of accuracy of our measuring system. And then the segments above, we showed had more than 11 degrees of increased motion compared to the spinal segments immediately above. And that was consistent with AMA Guide's definitions of increased translational motion. Well, as we continue through our permanent impairment discussion and our causation and apportionment discussion, I want to let you know that based upon the clinical presentation of this examinee, I consider to be the lower cervical segments, the C5, C6, and the C6, C7 segments, those segments that showed decreased intersegmental motion. I consider those to be the most clinically significant, whereas the two segments above that showed increased intersegmental motion, I consider those to be compensatory and secondary findings to the primary findings at C5, C6, and C6, C7, especially because the C5, C6 section of the spine was the one that showed advanced degenerative change accompanied by loss of motion or loss of intersegmental motion. So the C5, C6 area I consider to be the most symptomatic, and I provided for permanent impairment due to those two spinal segments, the C5, C6, and the C7 segments of the spine. So let's go through the permanent impairment discussion, and we'll highlight some important and interesting points relating to those arguments. Okay, so just to review, this is the actual section in our QME report, and it's entitled Diagnostic Studies. And here we list the findings of all of the diagnostic studies, including our own interpretation here of the new diagnostic studies. But let's just see what the medical radiologist said about these diagnostic studies at the time that they were ordered. He concluded that there was a reversal of the cervical lordosis, and there was moderate degenerative spondylosis at C5, C6, and degenerative grade 1 retrolisthesis of C3 on C4. So here the medical radiologist is describing exactly what we saw on those X-ray images. In other words, he's describing a badly diseased cervical spine for an examinee of 29 years of age. And he mentions here some sort of loss of motion segment integrity in his own language. And then it's up to us to do our analysis of motion segment integrity consistent with the AMA guides. So in my review of the X-rays here, I reiterate some of those findings, such as there's reversal of the cervical lordosis. This is due to subluxation and degenerative change of C5, C6. This is advanced, and it represents a localized finding. And I reference the analysis of motion segment integrity below. So we did our analysis last time, and remember that we came up with two areas of the spine, meaning C3, C4, and C4, C5, that had increased translational motion, meaning more than 11 degrees compared to the segment above. At least that applies to C3, C4. And then also two areas of decreased motion with C5, C6, the degenerative segment of the spine, showing complete or near complete loss of motion with only 0.7 degrees of movement of that vertebrae as the spine goes from the extreme of flexion to the extreme of extension. And let's just review those here very quickly. So here is the extension view that we're referencing. And here is that degenerative segment of the spine here at C5, C6. So this is an area of the spine that's showing almost near complete loss of motion throughout the entirety of the range between flexion and extension. Here's the flexion view. It'll be right here. And again, here is that degenerative segment showing near complete loss of motion, and the one below it showing a markedly reduced amount of motion. And this upsets the normal mechanics of the cervical spine and represents a great loss of function of the cervical spine. So let's go to our analysis of permanent impairment. Here is the actual permanent impairment section from this report. And all the names have been redacted, but the cover letter says, does the applicant have any permanent impairment? My answer to that is yes, that Ms. Stevens qualifies for permanent impairment of the cervical spine. And down below, I offer my permanent impairment according to three methods. I offer it according to the DRE method, the range of motion method, and an alternative rating under Almarez and Guzman, and then I provide my opinion of the most accurate description of Ms. Stevens' impairment. So under the DRE method, I opined for a DRE Category 2, meaning that the clinical history and exam findings are compatible with a specific injury. Findings include significant muscle guarding or spasm. And in this case, in the case of this examinee, the muscle guarding was manifested as pain with examination maneuvers and slight reductions in cervical spine ranges of motion, as well as a loss of the normal cervical lordosis. And many times, medical radiologists will refer to a loss of the normal cervical lordosis as a radiographic finding for muscle spasm. And let's see what the medical radiologist said about that. He said, let's see what he said. Again, noted, minimal, similar. Okay, in this case, the medical radiologist did not refer to the cervical lordosis as being due to muscle spasm, but many times they do. So you can consider a loss of the normal cervical lordosis to be a radiographic finding for muscle guarding and or muscle spasm. So according to the DRE2, that qualified for 5% impairment. I then provided for an impairment rating under the range of motion method, and I described her condition out of Table 15.7 as unoperated on, with medically documented injury, pain, and rigidity associated with none to minimal degenerative changes on structural tests. This qualifies for 6% whole person. And then I did her range of motion analysis. She had some reductions in flexion, minimal reduction in extension, minimal reduction in left lateral, minimal in right lateral. Rotation was preserved to the left and a minimal reduction to the right, which qualified only for 1.06% whole person impairment. The third component of the range of motion method, she did not have neurologic deficits associated with the cervical spine. So according to the range of motion method, her whole person impairment came to be 7%. So we had 5% under the DRE, 7% under the range of motion method. Well, here's the alternative rating under Almarez and Guzman, and let's just read it word by word. It says, analysis of new cervical spine x-rays shows that Ms. Stevens has a loss of motion segment integrity of the cervical spine. This is evident at two levels, at C5, C6, and C6, C7. And in this case, loss of motion segment integrity is manifest as decreased intersegmental motion at these levels. And then I quote from the AMA guides, alteration of motion segment integrity can be either loss of motion segment integrity, meaning increased translational or angular motion, or decreased motion resulting mainly from developmental changes, fusion, fracture healing, healed infection, or surgical arthrodesis. Okay? And in this case, Mrs. Jones or Mrs. Stevens had decreased intersegmental motion due to developmental or degenerative changes. So I said that this describes Ms. Stevens' conditions exactly, or at the least by analogy. She has decreased motion resulting from developmental or degenerative changes of the spine. According to Table 15.5, this qualifies for 25% whole person impairment. Okay, a substantial increase over 7% under the range of motion method and 5% under the DRE method. So 25% due to loss of motion at two spinal levels. Here I provide for permanent impairment rating only due to one of those spinal levels, which is the most symptomatic of the spinal levels, the level C5, C6, which shows moderate to advanced degenerative changes. So in this section, I provide 3 different permanent impairment ratings, and then in the next section on causation and apportionment, I provide my opinion on which of those methods is the most accurate and why. So the claims adjuster asks a specific question about causation and then later on about apportionment. So I answer all of those questions below. First, I handle her questions on AOE, COE, and then we can move on to the questions on permanent impairment here. So she wants to know, does Mrs. Stevens have any permanent impairment as a result of the industrial injury? My answer is yes, Mrs. Stevens does have permanent impairment related to the industrial injury. This affects her activities of daily living, and in my opinion, within reasonable medical probability, it's subject to apportionment due to the industrial injury, and 2, due to other factors as follows. So here I give my opinion on the most accurate permanent impairment rating. In my opinion, Ms. Stevens' permanent impairment is most accurately described as loss of motion segment integrity of the cervical spine. This is most pronounced at the C5, C6 level of the spine. Here, meaning at C5, C6, and also at C6, C7, she demonstrates decreased intersegmental motion due to degenerative changes. These are isolated findings, and for that reason, the use of loss of motion segment integrity to describe the permanent impairment is more accurate than the DRE method and more accurate than the range of motion method, because neither of those methods are specific for isolated changes within the cervical spine, while loss of motion segment integrity is specific for isolated changes in the cervical spine. To elaborate, Mrs. Stevens has headache and neck pain symptoms the result of specific and isolated degenerative changes at C5, C6, and C6, C7 levels of the spine. This pre-existing condition was aggravated by the industrial injury of 131.14. This condition is expected to quickly worsen, and this represents a significant loss of function of the cervical spine, and in my opinion, the entirety of the loss of function is most accurately captured by analogy to loss of motion segment integrity versus either of the DRE method or the range of motion method. And then here below, I then provide for my approximate percentages of the permanent impairment. Okay, so first we describe the most accurate method, and that is the alternative rating under Almarez and Guzman. And here, under approximate percentages, I say that in my opinion and within reasonable medical probability, only a small percent, only 20% of the permanent impairment is due to the industrial injury, 80% is due to other factors, and below I explain my reasons for this conclusion. And remember, for your opinion on apportionment to qualify as substantial medical evidence, you must provide the reasoning behind your opinions and conclusions, not simply just stating the opinions and conclusions. So here's some reasons. Number 1, she has a pre-existing condition. On 131.14, while in the course of her normal work duties as a registered nurse, Ms. Stevens aggravated a pre-existing condition of the spine. At the time, the cervical spine was variably symptomatic, and according to Mrs. Stevens, there were several occasions in the year preceding the industrial injury when she required chiropractic treatment to relieve neck pain symptoms. This indicates that the neck was becoming symptomatic in the time period leading up to the date of injury. And on 2/28/14, meaning shortly after the industrial injury, that was like about a week or so, 2 weeks after the industrial injury, which was on 131/14. So yeah, this is 4 weeks. X-ray studies indeed demonstrated a pre-existing and advanced condition of the cervical spine. So she had a pre-existing condition. Okay, well, what about the mechanism of injury? Over the course of 2 to 3 days leading up to the date of injury, Mrs. Stevens was involved in repetitive caring and moving of patients at Mercy Hospital. There was no one specific incident of injury, but rather the combined effect of this repetition caused the cervical spine to become symptomatic. In my opinion, this represents a minimal mechanism of injury. Following this, she had many months, perhaps 6 to 8 months, of total temporary disability. She received medical treatment, but unfortunately, even through the date of my evaluation, this QME evaluation that is, she continued to report ongoing symptoms and activity limitations. This suggests that other factors existed, preventing Ms. Stevens from making a complete recovery from an otherwise minimal mechanism of injury. In other words, if she did not have this pre-existing condition to complicate the injury and to complicate and confound the treatment, she would have otherwise recovered, especially after 6 to 8 months of being removed from the injurious environment of taking care of sick and elderly patients. So here we start to set the stage for how these other conditions, these pre-existing conditions, contribute greatly to the permanent impairment. So here we provide our approximate percentages. Absent degenerative changes of the cervical spine, Mrs. Stevens would have made a quick recovery from an otherwise minimal incident of injury. The degenerative changes contribute to the current permanent impairment. Absent the industrial injury, Mrs. Stevens would currently have permanent impairment of the cervical spine, although at a lower level and without the accelerative effect of the injury. I approximate these relative contributions to the permanent impairment as 20% industrial and 80% other factors. And I can state this within reasonable medical certainty because in the time period leading up to the industrial injury, Mrs. Stevens was having symptoms with the cervical spine, and she had received treatment on a non-industrial basis for the cervical spine. So that tells me that this degenerative condition and this aberrant or abnormal motion of the cervical spine was already causing her symptoms and already causing her some limitations in activities of daily living, and that by the time of the industrial injury, she would have had approximately 80% of those same limitations that she had when I evaluated her for this evaluation. So I opined for 20% industrial and 80%, the great preponderance, 4/5, being due to other factors. And when you provide your opinion on permanent impairment and apportionment, always add a statement of substantial medical evidence so that the parties will know that indeed your opinions and conclusions have been run through the filters described by Escobedo to qualify as substantial medical evidence. Okay, so this is an actual case, and every case is different, and you may opine differently. There is no right, there is no wrong, but this is just an example of how I opined in this case and how the loss of motion segment integrity finding contributed to my final opinion on permanent impairment. So if this opinion is upheld and the permanent impairment is 25%, she's going to get roughly 5% permanent impairment or benefits on 5% permanent impairment, which is roughly consistent with the DRE and roughly consistent with the range of motion, but in my opinion is the more accurate and most accurate description of the loss of function of the cervical spine. So that's very interesting. Would you agree? Now, even though the resulting permanent impairment due to the industrial injury in this case, in my opinion, is only 5%, that's the apportioned down permanent impairment. What if we had applied the same apportionment argument, meaning 20% industrial, and 80% due to other factors. What if we had applied that to the DRE Category 2 method? She would end up with roughly 1.25%. Let's see. She would end up with roughly 1% permanent impairment. If we applied it to the range of motion method, she would have been awarded roughly 1.5% permanent impairment. So in that sense, the differential and the benefits going to the injured worker are greatly increased by using the loss of motion segment integrity analogy under Almarez and Guzman too. Now, the apportionment percentages, if they were different, could reflect a much larger degree of permanent impairment due to the industrial injury. The point in this case is that we accurately described the permanent impairment, and in my opinion, she fully has 25% permanent impairment due to loss of motion segment integrity of multiple levels of the cervical spine. We only provided for one, but the point is she has a high level of permanent impairment. The unfortunate thing for her in this case is that not all of that was due to the industrial injury, and we had to apportion that out accordingly. But you may opine differently, and the permanent impairment could go up or down based upon your opinion on the approximate percentages. The point is that we provided for the most accurate description of her permanent impairment by the use of the loss of range of motion method. And isn't it a fascinating method to use? It gives you so much insight and so much understanding about the examinee's true condition and what's truly causing them symptoms and what's truly interfering with their activities of daily living, much more so than any of the lower DRE categories, which simply describe clinical exam findings such as muscle guarding and or non-verifiable radiculopathy physical exam findings. The analysis of motion segment integrity gets you an inside look into the function of the individual vertebrae of the cervical spine, and this can be done no other way. So I encourage you to adopt this method, because for those very reasons, it gives you great insight into the examinee's condition. And even if the examinee is not permanent and stationary, this may help you in providing a recommendation for further medical treatment. Perhaps you may recommend further chiropractic treatment, or you may recommend some physical therapy procedures directed at this dysfunctional level of the cervical spine. So it's a fascinating and a fabulous procedure, and I recommend that you do this on every single spine injury case. Now, in our next session, we're going to explore the same process and the same procedure as relates to a fascinating lumbar spine case. Again, I'll give you a little heads up. I'm going to provide for multi-level loss of motion segment integrity in the lumbar spine case for different reasons than we saw today in the cervical spine case. And I'm going to do a different formulation on the permanent impairment that actually provides for 40% permanent impairment due to loss of motion segment integrity. And I'll leave the surprise as to how we apportion that out for when we get there. So doctors, I hope this helps you, and I hope that you picked up several tips and suggestions that you can use in your very next series of cases. So this is Dr. Perry Carpenter. I look forward to being with you on our very next video. And for now, I'm wishing you best of success as a qualified medical evaluator.